This is a case we got from UERN Hospital. It is a motor vehicular accident we got from the surgery department. The general data of our patient ARG, is a Filipina, she's a call center agent, age 22 years old, and is an Iglesia ni Cristo that lives in Santa Mesa, Manila. The accident happened on 12:30 a.m. in February 3, Ortigas, Metro Manila, a motor vehicular accident. The medical chief complaint of the patient was just to follow up and check up on the following ER consultations 2 weeks prior to the treatment. Whereas the gentle, may agwat kasi yung ngipin ko, medyo nahihirapan akong kumain. She complains of difficulty of eating due to the spaces on her teeth. History of past illness states in the medical side says 2 weeks prior to consultation, the patient was seen in UERM emergency room due to multiple physical injuries secondary to a motor vehicular accident, non-collision motorcycle slammed into a wall due to loss of control, for which she saw treated with wound care and immobilization of the left hand using a splint and elastic bandage. In the dental aspect, 5 years prior to consult, the patient felt a sharp pain on the lower quadrant of her tooth while she was about to sleep. She rated the pain to be 5 out of 10. Medically, also in the history of past illness, the patient presently claims no pain and functional loss of the left hand, but claims a sore discomfort when the left elbow joint is fully extended both passively and actively. In the dental aspect of HPI, 4 years prior to consult, patient noticed that the teeth on her lower molars were cracked. 3 years ago, patient went for regular dental checkup and dentist noticed caries on her upper second molar as well as her upper third molar. Then, 2 years prior to consult, patient felt a sharp pain on her upper right quadrant. In the medical aspect still, the patient presently claims no pain and functional loss of the left hand, but claims to have a discomfort when the left elbow joint is fully extended both passively and actively. In the dental aspect, 1 year prior to consult, patient went for a dental checkup and the dentist noticed that both teeth 2.5 and 3.7 were already unrestorable. 6 months prior to consult, the patient went again to the dentist for her regular cleaning and was told that tooth 2.6 and 4.7 are in need of a tooth restoration. Still on the dental, on the day of consult, patient neither complains of pain or sensitivity on her teeth but had concerns of spaces on her teeth that were making it difficult for her to eat properly. In the past history, medically, she had unrecalled immunizations but has said to have undergone. She had experienced an accident and she is negative of surgery and allergy. In the dental aspect of past history, she undergone composite restorations on tooth 17, 18, 26, and 47, and tooth extractions on tooth 15, 16, 25, 36, and 37. Personal and social history. The diet of the patient is normal, usually with lots of fruits. She exercises as commuting to work every day. She occasionally drinks alcohol and a non-smoker. She is single but she is currently in a relationship with her boyfriend.
Immune systems. For the general, there is no complaints. Skin, there is no complaint. For the head, there is also no complaint. For the eyes, there is no complaint. For the ears, the patient has no complaints. For the throat, the patient has no complaint. And for the neck, patient has no complaints. Breast also has no complaints. For the respiratory, the patient also has no complaints. For the cardiovascular, patient has no complaint. For the gastrointestinal, the patient has no complaints. For the urinary, the patient has no complaints. And for the genital also, the patient has no complaint. The peripheral vascular, the patient has no complaints. Muscles, bones, and joints and legs, the patient has no complaints. Psychiatric, the patient also has no complaints. For the neurologic, patient has no complaints. Hematologic and endocrine, the patient has no complaints. For the objective part, general appraisal. For the dental, the patient is calm and attentive, well dressed and properly groomed. No sense of distress noted. For the medical part, patient is awake, alert, oriented to person, place, and time. Patient is well responsive and talks in an orderly manner. Able to follow commands without any difficulty, and patient behaves properly. For the continuation, for the medical, able to ambulate without any assistance needed. Patient is well dressed for the weather and properly groomed. No sense of distress noted. For the vital signs, patient's temperature measures 36.5 degrees Celsius, taken on the brachial part. Pulse rate is 78 beats per minute, respiratory rate of 18 rates per minute, blood pressure of 110/80 mercury per millimeters. This table shows the normal heart rate by age, normal respiratory rate by age, and normal blood pressure by age by the PALS Guidelines 2015. Now for the anthropometric measurements, this table shows the normal BMI for the Asian criteria. For the physical examination, the skin, it is warm and dry to touch, negative rashes, negative scab. For the head, hair is of average texture, scalp without lesion, normocephalic and achromatic. For the eyes, vision is normal, visual fields full by confrontation, conjunctiva is pink, sclera is white, pupil constriction is normal, round, regular, equally reactive to light. Disc margin is sharp without hemorrhage and exudates. For the ears, right and left canals are clear, tympanic membrane with good cone of light, acuity good to whispered voice. For the nose and sinuses, mucosa is red, septum is in midline, and positive in sinus tenderness. For the throat, there is no sense of inflammation or pus formation. This one shows the dental chart of the patient. For the extraoral examination, the face is symmetrical, the TMJ clicking sound is absent, pain and swelling is absent, lips examination, there are no cracks and fissures, no signs of ulcers, the lymph nodes are not palpable, and facial profile is straight. For the intraoral examination, oral hygiene is good, gingival color is pink, gingival consistency is firm, no signs of pathology. For the tongue, no elevations and fissures, and negative coated. Position of tongue is normal, and the occlusion is not taken. For the neck, trachea is on the midline, thyroid isthmus barely palpable, lobes not felt, lymph nodes are not palpable. For the thorax and the lungs, thorax symmetric with good excursion, lungs resonant, breath sounds vesicular with no added sounds, diaphragm descends bilaterally. For the cardiovascular, jugular venous pressure 1 cm above the sternal angle, upstroke and amplitude bilaterally without breath, apical impulse discrete and tapping, and barely palpable. Good S1 and S2, and negative diastolic murmur. For the breast, pendulous and symmetric, negative masses, nipples are without discharge, abdomen, protuberant, negative scar, and striae, negative masses and tenderness, liver edge not palpable, spleen and kidney not felt. No costovertebral angle tenderness. And for genitalia, external genitalia without lesion, vaginal mucosal pink, cervix is pink, parous and without discharge. Uterus anterior, midline, soothed and not enlarged. No cervical or adnexal tenderness, rectovaginal wall intact. For the rectal bones without masses, stool is brown, negative for occult blood. For the extremities, warm, without edema, calves supple and not tender. For the musculoskeletal, no joint deformities, good range of motion with hands, wrists, elbows, shoulders, spine, hips, and knees and ankles. For the neurologic, mental status, alert and cooperative, cranial nerves, 1 to 12 intact, motor, good muscle bulk and tone, strength, 5/5 throughout. Cerebellar, rapid alternating movement and fluid movements. Sensory, pinprick, light to touch, position sense, vibration, and stereognosis intact. Now for the assessment, for the dental. Diagnosis, Class 3 mesial caries on 2.2 and 2.1, Class 1 recurrent caries on 1.7, edentulous areas on 2.15, 1.6, 2.5, 3.6, 3.7, 3.8, 4.6, and 4.8. For the medical assessment, diagnosis, medial dislocation of the third proximal phalanx in relation to the third metacarpal bone. So what is phalanx dislocation? Common traumatic injury of the hand involving the proximal interphalangeal joint or distal interphalangeal bone. Treatment is close reduction and splinting unless volar plate entrapment blocks. Next is phalanx dislocation. Injuries pattern can be broken into PIP joint dislocations, volar, dorsal, lateral, fracture dislocations. Continuation, PIP joints dislocations, volar, dorsal, lateral, fracture dislocation. DIP joint dislocations, fracture dislocations, associated conditions, swan neck deformities, nail bed injuries, usually associated with distal phalanx rupture.
The diagnostic plan for the dental, panoramic x-ray, dental chart, study cast, intraoral photographs, extraoral photographs. In the medical, repeat x-ray of the left hand and arm. So for the treatment plan in pharmacologic, dental is none, and the medical continuous celecoxib 200 mg tablet, Q12 as needed for pain. So for the treatment plan for non-pharmacologic, for dental is oral prophylaxis, tooth restoration, upper and lower fixed partial dentures on the edentulous areas. For the medical, bed rest for 2 weeks and immobilization. Continuation for the non-pharmacological is, for the medical is moderation of alcohol consumption, limit consumption to no more than 2 drinks per day in most men and to no more than 1 drink per day in women and lighter weight persons. So for the journal, this is reported by Morali et al. In December 2013, and it is a rare case of close isolated dislocation of the third metacarpophalangeal joint of the hand. So the abstract is the MCP dislocation of the index, little, and thumb are common. That of the middle finger is very rare. In all the literature consulted, only 5 cases of isolated closed dorsal dislocation of the MCP joint of the middle finger have been reported. Hyperextension of MCP joint is the mechanism of injury. We are herewith reporting a case of isolated MCP dislocation of the middle finger, and one of the medical students while driving a motorcycle fell down in the road and sustained lacerated wound over the hypothenar area of the left hand. There was prominence of the head of the third metacarpal of the volar aspect, and the base of the proximal phalanx was prominent dorsally. MCP dislocation of the middle finger was our clinical diagnosis, which was confirmed by the radiograph. The patient had reported within 60 minutes of the accident, and there was no tendon injury. Wound debridement was done, and wound was extended to the back of the middle finger. The volar plate, which was interposed between the head of the metacarpal and the base of the proximal phalanx, was repositioned, and the dislocation was reduced. Reduction was stable, and the patient was reviewed after 14 months, and the function of the hand is satisfactory. The case is presented for its unique presentation. This is the 6th case of isolated dislocation of the MCP joint of the middle finger. So for the introduction, isolated metacarpophalangeal joint dislocation of the middle finger is very rare. Some of these MCP dislocations are complex and require open reduction. Rockwood and Green state that there are no case reports in the literature of isolated dislocations in the ring of long fingers. These injuries are most common at the index and little fingers where pathology and operative management are well documented. There are only 5 cases of isolated dorsal MCP dislocation of the middle finger in the literature. So these are the case reports of MCP dislocations of the long finger. There are 5. So for the case report, a 22-year-old medical student reported to us after fall from the bike while he was riding. He had a lacerated wound over the left hypothenar area running up to the base of the ring finger. And there was no tendon injury, and the head of the third metacarpal was prominent anteriorly, and the clinical diagnosis of MCP dislocation of the middle finger was made, and it was confirmed by the radiograph of the hand. As the patient had reported to us within an hour after the injury, wound debridement was done without any delay under the general anesthesia. Close reduction of the MCP dislocation of the middle finger was attempted. As it was not successful, the wound was extended to the base of the middle finger. The volar plate was found to be interposed. Same was relieved and reduction of the dislocation was done. Joint was stable after open reduction. The finger was immobilized in functional position for 3 weeks. And the patient was reviewed after 14 months according to Solerman hand function test. He had a score of 79 for the injured left hand and 80 for the right hand. Hand grip and functions were full, satisfactory, and he resumed to his original work as a student. So these are the post-operative photos showing the phalanxes, and this is after 14 months, and this is the lateral view at 14 months. So for the discussion, dislocation of the MCP joint of the middle finger is uncommon. Hyperextension is the usual mode of injury. Most of Busuj et al. Reported 2 case reports of MCP dislocation of the middle finger, and they have done open reduction through the dorsal approach. Both their cases were old dislocations, 7 and 18 months old respectively. Ours is a fresh case, moreover, he had a lacerated wound over the palm, so we had a volar approach. In all the literature concerned, only 5 cases of isolated dislocation of the MCP joint of the third finger had been reported. We found, as others, that in a dorsal dislocation of the MCP joint, the volar plate, which is detached from the weakest attachment to the phalanx of the third finger, is always interposed into the joint. This is the most important element preventing reduction. Our findings are in line with those with Mustafa et al. And Nussbaum. So conflicts of interest is that no benefits in any form have been received or will be received from a commercial party related directly or indirectly to the subject to this article. So for the dental relevance, these are the common anti-hypertensive dental side effects. For the beta blockers, the side effects are dry mouth, taste changes, like in reaction. ACE inhibitors, dry cough, loss of taste, dry mouth, ulceration, angioedema. For the angiotensin II receptor blockers, dry mouth, angioedema, sinusitis, taste loss. Calcium channel blockers, gingival enlargement, dry mouth, altered taste. For the alpha blockers, dry mouth. And for the D-alpha-2 agonist, central acting, dry mouth, lichen reaction, orthostatic hypotension. For the diuretics, facial flushing, possible increased risk of gingival bleeding and infection. For the vasolators and renin inhibitors, angioedema, rash, cough, tinnitus, parosmia. And for the peripheral dopamine 1 receptor agonist is leukocytosis, bleeding. And peripheral adrenergic inhibitors is dry mouth, swelling, and nosebleed. Thank you.